Good morning, everyone. Welcome to the 2013 Advantage Health Plans Users Group Meeting, Annual Users Group Meeting. I'm here with my co-presenter here, Maria Robles Meyers. Hope everybody's having a great morning. We're going to try to get through this as quickly as possible, so we'll have plenty of time for questions or comments at the end. But again, I just wanted to welcome everybody. I know everybody's time is valuable, and here in the last few days, we've gotten a tremendous amount of questions regarding the Affordable Care Act, and so Maria is definitely going to be talking a little bit about that as we get down through the presentation. Already gave the introductions, but the agenda real quick. This is going to be definitely a good news message. Advantage Health Plans has got some good, exciting things to report. Consumerism and free market principles. We were at the IBAT convention last week, and I was talking to some bankers and talking to the IBAT staff, and Advantage Health Plans is run a lot like a community bank. We don't take federal money. In fact, we really don't like even the thought of working with the federal government if we can keep from it. Maintaining autonomy, maintaining the ability to run and manage this plan in the best interest of its participants as opposed to in the best interest of some federal health plan is really what Advantage is all about. It's owned by you, the banker, and that's something that I want everybody to kind of keep in mind. The Board of Trustees that run Advantage, they are all community bankers. They think about things just the way that you do, and we've actually here in the last few years have really been able to dive into kind of this free market approach to healthcare, and it is really yielding some amazing results. We're also going to talk about some new programs to keep the momentum strong. Anne Marie is going to talk a little bit about the ACA, and we'll have Q&A time at the end. I want to introduce the trustees of Advantage Health Plans. Again, these are your elected representatives on the health plan. They are the ones that we report to, and these are the gentlemen that represent you on the health plan. First, our chairman is Roy Nelson. He's the chairman of the board at the First National Bank of McAllister. We also have Jeff Nunn, which most of you all probably know, at Citizens Bank in Claude, which is up there in the Texas Panhandle. Lynn Kinder, Payne County Bank in Perkins. A.B. Bayouth at Exchange Bank in Skytook. John Shelley. We've recently started a new advisory board position, and we have two advisory trustees. One of them is Paul Freeman, which is the immediate past chairman of Advantage. And also Guy Sims is another past chairman that is also in an advisory capacity. And last but not least, we also have Robert Jennings from People's National Bank in Chakota and Kurt Pittman from First National Bank of Sealing. Maria her capacity here is she works for Advantage Health Plans. She actually is the dedicated attorney for Advantage Health Plans, and she also does some work with me and my firm at the Kempton Group. But Maria has been she's been in the welfare business for a long time, and is very, very knowledgeable. Of course, I'm Jay Kempton, the administrator of Advantage Health Plans, and we're also guest speaker is Dr. Keith Smith from Surgery Center of Oklahoma is going to be here to talk a little bit about free market and how the providers and the rest of the country are reacting to some of the free market principles that we're starting to enact. Last year, you all will remember the main theme, and we just went on and on and on about it, but the main theme was, this is your health plan. You need to start looking at it and treating it not like from a buyer's perspective, but truly from an owner's perspective, and take an ownership mentality as opposed to just a consumer mentality, and you've done that. The Texas banks as well as the Oklahoma banks have come so far. We get calls all the time from Texas bankers saying, hey, my doctor's recommended that I have some procedure done, and I just wanted to talk to you all to make sure that I'm getting the most bang for my buck, because I want to make sure that I get a good deal, I get high quality care at a good price. those kind of conversations were few and far between historically, and they're becoming very commonplace now. So we wanted to definitely congratulate the bankers. Your hard work is definitely paying off, starting to think outside the box when it comes to healthcare. As we've talked, Maria, and with consumerism and bringing the free market to healthcare, we're really talking about unwinding a generation of conventional thinking about healthcare. And so it's if it's hard or it seems like it's it's very odd or strange, you're absolutely right. It's strange for everybody, but it's something that as Americans we know very well how to be good consumers. We've just been told for a lot of years that healthcare is different. Healthcare is something that you don't really need to worry about price. And that's all well and good if you have an unlimited supply of money to pay for it. So anyway, with that being said, we'll kind of jump right in and look at some of the metrics.
If I could just
Sure.
interject for a moment, one of the things that I think is going to happen this year as a consequence of the exchanges or the marketplaces opening up is I've glanced at some of the plans that are out there, and the deductibles are high, the out-of-pockets are high, the co-payments are high. And I think because those are really going to come out of the individual's pockets, I think you're going to see a little bit more of individuals, the consumer side of healthcare, where people are going to start actually thinking about what they're spending, because the money is going to come out of their pockets when they get this healthcare, and that's something that they really haven't done
Right.
as much in the past. So I think it's going to be a growing thing, not it's not going down. It will continue to grow, and I think the exchanges will actually promote it in a manner.
You're right. As deductibles and out-of-pockets get higher and people start looking at well, my gosh, for this procedure, this is coming out of my pocket. Yep. Just like we said before, what's coming out of the individual patient's pocket, boy, all of a sudden they start looking at this just like any other buying decision. Yep. And they want to make sure they can stretch that dollar. And that's really the concept here. Advantage Health Plans is all your dollar, from the CEO all the way down to the brand new teller. It's all your money. There is no insurance layer in Advantage. But some of the metrics that we wanted to talk about, APP, that's just our acronym for Advantage Premier Provider. This is actually old. We had our biggest month for Premier Provider utilization in September. So we've been doing this for 21 months, and last month was the biggest. This was as of August 31st. We had done 237 procedures for Advanced Health Plans bankers through one of our Premier Provider arrangements. As of August 1st, not 31st, as August 1st, the savings just from Advanced Premier Provider utilization is $2.4 million. We really think that by the end of the year, that's going to be at $3 million. It's really stunning. It really is. We've never had any sort of a cost containment program that we've ever put in place in 40 years of operation that has yielded that type of result. And the thing that we talk about in employee meetings, and we hear it from bankers all the time, is that we're able to save the health plan a lot of dollars, but we're able to do it by simultaneously either eliminating or greatly reducing the employees out of pocket, which is, I've been doing this for 21 years personally, and I've never, anytime anybody talks about, hey, we're going to lower your health plan cost, that usually is being done by raising deductibles, increasing copays, or co-insurance. So really excited about those results.
And one of the things that I think is important to point out, that $2.4 million that's shown there as of August 1, that's what the trust has saved, because the cost that it paid for those procedures is so much lower than the cost that would have been charged had the participants gone through the individual means. That number does not include what individuals saved, because when they went through the Premier Provider process, they didn't pay any out-of-pocket, right, and they didn't do any co-payments, they didn't do a deductible. So those are amounts that the individual employees are saving out of their pocket that are not included in that number. And I think it's important that people realize that and kind of keep that in the back of their heads.
Right. That is a great point. And I think we actually did a Solutions from Services article in IBAT where we had talked a little bit about a particular bank that I think they had 6 or 7 Premier Provider utilizations done, saved the bank's health plan about $63,000, but because of the deductibles that this bank had, it saved the individual employees some like $40,000. in aggregate deductibles and out of pocket. So thank you, Murray, for reminding me of that. That's a big deal. Prescription utilization. We've sent out a lot of information about buying better on prescriptions, whether it be generic utilization or just finding therapeutic alternatives to name brand drugs and buying better, taking advantage of some of the, for instance, we have the 100% out of over-the-counter benefit for prescriptions. A lot of our bankers either didn't remember that or just hadn't really understood how it worked. But through a lot of our education that you all have enabled us to do through flyers and email blasts and distributing that out, we've actually seen a net reduction in prescription costs over the last year. Again, last year I was telling you about how prescription utilization and costs was going up at, I think it was 11-12%. Now it's actually gone down for 2013, which again, it's done, it's a result of your action in being better consumers. One Call, which is our imaging, kind of our imaging program. Think of it as kind of like a PPO, and you all know I'm not big fans of PPOs, but One Call is better than, it's kind of a PPO on steroids, but when you need to have an MRI or a CAT scan or a PET scan done, you make that one call to them and they will make an appointment with a more efficient, lower cost, high quality facility. We've had 229 scans that have been provided by One Call in the last year with an average savings of $289,000. Again, a big deal.
Now, Jay, that's the same as Premier Provider, isn't it?
It
The
absolutely
employee
is.
doesn't, when they use the One Call, the employee doesn't have an out-of-pocket cost.
Yeah.
So the savings, again, shown there for the trust, don't include what the individuals who use those 229 procedures saved in their own out-of-pocket costs
That's
as
right.
well.
We do structure One Call utilization like a Premier Provider, and I keep, I guess I assume that everybody knows that, but thank you continue to remind me that, yeah, when that utilization happens, the employee is not out anything, and as Maria always likes to remind, it is free to the employee, but it's absolutely not free. Bankers understand that nothing's free, but it does reduce or eliminate the employee's out of pocket. Lab card, we've had 1,187 lab procedures that have been done at Lab Card. Again, we have better pricing through a Lab Card facility. In some of our banks in Texas, we've actually been able to do some direct negotiations and some direct arrangements with some independent labs. A lot of times we don't know about those labs that would be willing to negotiate until we hear about them through you. And so, again, Lab Card is a wonderful thing, but they are essentially a broker of discounts. I mean, they're selling access to better pricing. If we can just simply put the buyer, which is the health plan, and the seller, which is the lab, together and have a direct relationship, a lot of times we can get additional savings and reduce a complete layer of bureaucracy. Healthcare Blue Book, that's a initiative that we did in January. To date, we've had over 7,000 searches on Healthcare Blue Book, which is huge. And it, again, works very much like a Kelly Blue Book, and it's simply to highlight and communicate to the employees what providers, whether they be doctors, hospitals, labs, whatever, the ones that are lower cost and also shed some light on their quality as well. Premier providers are also, obviously, they're highlighted in Healthcare Blue Book as definitely almost like pricing benchmarks, and they are color coded for green providers, red providers, and yellow providers. Of course, we want people to use the green providers. That's why we've had our Go for Green initiative.
And you might mention, I actually was looking just for my own edification here on the Healthcare Blue Book side, and there is an app that is available for iPads and iPhones and Androids that is really easy to use.
Yes.
And that letting people know that it's that easy, it's at their fingertips. It's not like they have to go out of their way to really
Right.
go hunt for the information. Most everybody has access to it, either on the phone or on a mobile unit or an iPad or their computer. It's
Yeah.
very easy to use.
And we've seen some utilization, and we'll talk a little bit more about Healthcare Blue Book, but the mobile app is really intended for when that employee or that patient is on their way to the doctor's appointment, and they say, hey, I think I got a sinus infection. I wonder what a office visit should cost. And they can look it right up on Healthcare Blue Book sitting in the parking lot, and hopefully they'll have that discussion with their medical provider that, hey, what are you going to charge for this? And the doctor will first look at them like they're crazy. Why do you care? How do you know this? And of course, the employee can say, well, hey, I have access to some of this pricing through Healthcare Blue Book. So. Again, I said I'm not a big fan of PPO discounts. More evidence of why. These are some every one of these are actual utilization. We had some examples of this last year. We've got more this year. For instance, there you can see that bilateral knee replacement, actual participant, Texas participant on that one had bilateral knee joint replacement. The billed charges from their provider was just a hair under $200,000 were the billed charges. The network discount on that brought it down to, I think, $153,000. The premier provider, which in this case would have been either Pine Creek in Dallas or McBride Orthopedic Hospital here in Oklahoma City, their cash price for that bilateral knee joint is $30,000. When I say these things and I give these examples, I can just almost see, especially if first time you've heard it, I can almost see the audience look that I'm telling them, I'm fibbing to them, because this just can't be right. But it is right. It's what we're experiencing.
And what it really represents when you do the numbers, if you're paying $150 and it could have cost you, what was it at McBride? 30. You're looking at the trust paying $120,000 more for that one person, that one procedure that could have been saved in the trust had they chosen to use the premier provider.
Right.
That's real money going out of the trust.
And, the dirty little secret, I actually had a PPO representative actually in this very room where we're doing the webinar earlier this week. And the dirty little secret out there that I think is going to get more and more attention is that there is actually a repricing scheme, if you will, out there that's very commonplace. I brought it up to her, and she just acknowledged that, yeah, that's how we make a lot of our money. But how that works is, for instance, on that bilateral knee joint replacement, the billed charges were so high, and of course they were able to get a $50,000 discount. But the way that works is if they discounted that down to $150,000, they may have actually gotten a discount down to $140,000, but kept $10,000 of it, and the PPO company pockets that. That is I had a pretty spirited discussion with her that that is a very, very slippery slope, that when any entity in healthcare starts to stick their hands in the cookie jar of claims, then all of a sudden they're incentivized to make some pretty egregious business decisions. When they're out there negotiating on a health plan's behalf, along with a hospital, there is an actual incentive for them to negotiate with the hospital to charge more, so they can show a bigger discount, so they can take a bigger cut of that discount. I actually had go to the next slide with some more examples. I was actually having a conversation with a banker in Texas at the IBAC convention. They're not with Advantage Health Plans. They're with Blue Cross. We've got an appointment with them, though, in a couple of weeks, so hopefully that'll work out. But they were commenting that they had some surgery done, and the bill charges, I can't remember the exact numbers, but let's just say that the bill charges were $50,000. And after Blue Cross negotiated it, they were able to negotiate it down to like $14,000. And she just came up to me and she just looked at me. She goes, I just don't buy this anymore. I just don't, these numbers, she goes, I just don't feel like the bill charges were obviously monopoly money. There was no rhyme nor reason to that. The discount that, just because Blue Cross comes onto the scene and they can negotiate that down by a huge percentage, she goes, I just have a feeling that I don't know that I'm being told the truth by the bill charges or the discounted amount? She goes, I wonder what the cash price is. And I said, oh, you need to come to our booth because we need to talk. And so when she was arriving, I mean, bankers, you all are very smart numbers people, and you kind of get that. Again, examples here of a hernia repair, carpal tunnel, arthroscopic knee surgery. The differences between the bill charges, the PPO pricing, and then the green is actually the premier provider price. It's absolutely stunning. You can really see how the health plan can waive deductibles, copays, and coinsurance. Premier providers, the concept of free market transparency in healthcare is growing. It's growing pretty rapidly. I think the last time we spoke with you all, I think we had maybe 6 premier providers. We're actually at 10. We've added a new one since the slide was created. All of them, unfortunately, right now are in Oklahoma, with the exception of Pine Creek, which is there in Dallas. But the good news is that we have a lot of coming soons, as you can see there on the slide. Several of them in Texas, Austin, Dallas, Frisco, New Braunfels, the Christus group down in, I believe, San Antonio. Those are all providers that we're negotiating with. Just to give you all a little bit of feedback, they've been on our coming soon list for a while. There is unfortunately, there is a idea or a concept that I like to call opaque transparency, that these providers, they kind of get the concept, but they're not really ready to be above board and compete openly. And so we're continuing to have to kind of chisel away. There is a will, so hopefully we'll find a way. But if anybody has a relationship with any of those facilities and has the name of a decision maker, I'd love to buy a plane ticket and fly down and talk to them a little bit about it. But it's a new concept for them, and a lot of times they'll actually tell us that, well, there's nobody else in our area that's doing this, so why would we want to compete openly and honestly for patients? And it's a supply and demand. It's a competition thing. If they don't perceive that they have competition, they can continue to kind of set their pricing the way they want. Healthcare Blue Book. We've talked a little bit about Healthcare Blue Book. I wanted to remind everybody that in July of this year, we kind of enhanced the Healthcare Blue Book program by having a new aspect to it called the Green Rewards Program. And for those certain procedures that you see on the list there, colonoscopies, upper GI endoscopies, sleep studies, cataract surgeries, etc. For those particular procedures, and the reason that those procedures are on the list and not others is those were chosen because there's so much price variability between providers. And when I mean a lot of price variability, I'm talking up to 1,000% difference, if you can wrap your mind around that, between providers that charge for these procedures. And so if the employee goes to Healthcare Blue Book for one of those procedures and utilizes a provider that is coded green or is at or below the fair price, then your health plan, Advanced Health Plans, will pay that employee back a green reward. And these dollars can be used for anything. They don't necessarily have to be used to buy down a deductible or an out-of-pocket. They can actually be used for whatever, car payment, gas, dinner out with their spouse, whatever. But we want everybody to continue to remember that. And as the program evolves, that list is probably going to expand as far as the number of procedures that have green rewards on them. There's no forms or anything for the employees to submit, which is a really nice thing. They simply utilize a green provider. We will know that they've utilized a green provider, and then Healthcare Blue Book will cut those reward checks back once a quarter. So we're actually going to be due for our first green rewards rollout here pretty soon. And so hopefully there'll be some of the Texas bankers that have availed themselves of that.
It'll be interesting to see
It will
the
be.
people that call in and say, I got a check over here.
Yeah, how
What do
did
I do
that
with it?
happen? And that's true. 'Cause you may have people that get checks, may get green rewards because they didn't mean to. They just happened to use a more efficient provider, and we want them to start recognizing that when they buy better, their out-of-pocket should be less. That's the same way it works outside of healthcare, right? I mean, if you buy better, You buy a flat screen TV you find one that's on sale, same quality, less out of pocket. It's axiomatic. And so we're trying to bring that to healthcare. Again, that last bullet, premier providers are always shown in green, not because we've just plugged them as green, it's because they are always, they have proven that their pricing is always, it's usually kind of top of the class. I want to back up real quick because I want to address quality for a moment. What we see is our premier providers, the providers that are willing to embrace free market transparency and compete for patients based on open pricing and quality, are really, they're the ones that are at the top of their game. They're not the fly-by-nights. The facilities that don't have good quality, they're unwilling to actually put a price out there. They are very used to being able to kind of hide behind the PPO networks and their TV ads and their billboards. And so to kind of bear that out, the three facilities that are highlighted in red, McBride Orthopedic Hospital, Oklahoma Heart, and Oklahoma Surgical Hospital, were actually ranked as some of the top facilities in the United States. In fact, in Oklahoma, McBride was ranked #1, Oklahoma Heart #2, and Oklahoma Surgical Hospital was ranked #5 as the top hospitals in Oklahoma. And you know, actually, I would put those facilities up really against almost anybody in the region or even in the nation.
I think McBride, on the Consumer Report, I think McBride and Oklahoma Heart actually ranked in the top 5, like 1 or 2 in the nation.
Yeah.
I mean, it's not just in Oklahoma. Their ranking was national.
And our friend Dr. Smith will be on here in a minute. He's going to tell you why he's not ranked. There's actually a very good logical reason for that. But I'm sure he's eager to talk about that as well. Okay, moving on. Competition in the marketplace. This is really a great story, and it's something that is really going to mean something to our Texas banks. And this is actually kind of a case study. This has actually happened. It was an Advantage Health Plan's customer in Oklahoma. His gentleman's name was Ira Horner. He's from Woodward. We do have his permission to utilize his private health information here, but he needed surgery for a torn meniscus in his knee. He already had a relationship with an established facility and orthopedic surgeon. That facility was not a premier provider. They were just in his PPO network. Like a lot of the facilities that are in Texas right now, you know, don't have any premier providers in Texas other than Pine Creek. And that was the situation that this gentleman was in, is that his provider that he really felt comfortable with was not a premier provider. And so he went to his pre-surgical consult, and they sat him down with the financial advisor and said, okay, well, you know, Mr. Horner, here's how much of your deductible's been met. Here's how much out of pocket you have. And so they were really kind of calculating up his financial responsibility for utilizing their facility. And he had remembered that we had an employee meeting a while back talking about premier providers and free market healthcare. And so he did a great thing. After he left that facility, he gave us a call and had a discussion with his account manager here at Advantage. And it said, you know, Mr. Horner, yes, you know, you do have an enhanced benefit if you utilize a premier provider. You know, you wouldn't have any out of pocket. Of course, he would only be driving across town, not across, you know, Texas and Oklahoma. But he said, well, you know, that's great, and I really, you know, the other facility has a great reputation as well, but I really want to stay where I'm at. Is there any way that if they matched the pricing of the premier provider that you know, you all would pay that at 100%? And we kind of thought about that for a minute and said, you know, there's absolutely no reason why that couldn't happen, because this is not some sort of a contractual PPO agreement or anything else. This is the free market at work, and he was trying to harness the power of the free market, and that's what he did. We actually made the phone call for him and kind of told the facility what was happening, that, you know, you have a patient here that's already scheduled for surgery, but because, you know, we don't have any idea of what the price of the procedure is going to be at your facility, and Mr. Horner has got a large out-of-pocket cost, and we have, you know, several standing offers of cash pricing at other facilities. Mr. Horner wants to use your facility, but he is willing to vote with his feet will you match the standing offers at these other facilities? And well, just to put it mildly, they kind of lost their minds. They had never had that happen before. They've never had a patient have a better offer and be willing to walk out the door. And so after they were not pleased with us or Mr. Horner, but after the dust settled, they did relent, and they did match the pricing of Surgery Center of Oklahoma. The gentleman got to use the facility that he wanted to. I'm assuming he had a good outcome, but the pricing was $3,400. And after talking with the facility, and actually we looked at some of their past claims, the pricing outside of, if we weren't able to negotiate with that, the PPO pricing was $14,000. And so you can see why they didn't really want to negotiate, but other facilities in their region were able to match that price. And so that was such a cool example of the free market at work that actually ABC News picked up that and ran an article on their health site. And so we've got the link right there. Really all you need to do is go to abcnews.com, click on the health article, and I think you should be able to probably type in Surgery Center of Oklahoma, and I think that'll pull up that article. Anyway, that was a great thing. Again, for Texas banks, you all may have, at least for the time being, you all may have situations like this where Advantage health plans will pick up your travel and your lodging expenses if you move, but this is not about just driving everybody to Oklahoma. Of course, if it happens, it's fine, and I'm sure Dr. Smith would love that as well. But trying to allow this free market to work and spread, a lot of times market forces are what's going to enable that to happen, and the current healthcare system doesn't support that. It just doesn't.
I'm sorry, I'll
Yeah.
just add a quick comment. I think when you see that kind of an example, there are others like that. And what it really is, it's an individual who is willing to take the concept of understanding what healthcare really costs, not what their out-of-pocket is, not what their
Right.
deductible is, but what really is the cost of the service that he's going to get. And be able to take a stand on it and do it because he chooses to do that free market principle. And it is a person-by-person deal. And I think that the thing that's really important is that the empowerment of an individual to be able to go to a doctor or facility and say, I'm not willing to just pay whatever it is you're going to charge me. I need to know up front.
And find out 3 weeks later.
And here's the price that that's willing to be paid. Do you want it? And it's no different than buying a lot of other services that people normally would buy for. But the ability of that person to be empowered to take the initiative and do it, I think, is awesome. And
Yeah.
that's the part that needs to be repeated.
Had a Texas banker at IBAT actually give me a great analogy, and that is just like buying a new car. If you're a savvy negotiator, you never walk into the car dealership and just try to work out a deal. If you want to have some negotiating power, you've got to go to 2 or 3 other dealerships and get their best deal. And that's how we negotiate, and we all know that, but we just don't think that that's possible in healthcare, and that's starting to change.
It is possible.
It absolutely, we're proving it that's possible. With that, we're going to move on, and Dr. Smith is going to come in and speak a little bit. We want to thank Dr. Smith for taking time out of his busy schedule to come and talk to us here at Advantage and the community banks of Texas. And Dr. Smith, of course, we're not in a studio, and you probably gathered that we're not necessarily professionals at this, but we're going to slide down and have Dr. Smith come in.
Hi, thanks for having me. I've been traveling and speaking a lot, and I've gotten to where I start off by saying that I shouldn't be here, that we have decided to say this is what we do and here's how much it is novel in healthcare is an indication of just how awry things really have gone. I'm really excited though because there are a lot of developments that point to just exactly what Jay and Maria said, that this cat is out of the bag. This transparency in healthcare, cat's out of the bag, and there's really not any stopping it. And I think the more that the federal government with their scams like the Unaffordable Care Act, the more they clench their fist and try to get control, the more paradoxically they will create and are creating a consumer-driven market. Many of the deductibles that I saw in some of the exchange plans were high enough that people could pay completely out of pocket for the procedures that we have listed online. So as people have more and more out-of-pocket exposure, I think that that they ask, they're spending their own money, and they ask the same question. People spend their own money, want to know how much does it cost, and they want to know that up front. And the facilities, the physicians that respond to that, they're going to do well, and they're going to just be very, very busy, and we're already seeing that at our place. The facilities that don't are going to see patients walk out of Austin and Houston and all over the place. I think more and more facilities, though, will see patients with a plane ticket in one hand and our prices in another, or McBride Clinic Hospital's prices, or Oklahoma Heart. And we'll see more and more leveraging of better deals. And physicians, I know this, they tend to respond to fear more than anything. And it won't take 10 cases that an orthopedist or a urologist or a gynecologist has lost to a facility like mine before they start to scream at their local community to, the facilities to respond to this. It's very, very scary for these physicians and facilities to lose business to us. Somebody the other day asked me, when am I going to open up a facility in New Jersey? And I told him I had no plans to open up a facility in New Jersey. I didn't have to, that there were plenty of people from New Jersey coming to Oklahoma City. And they said, well, our company is self-funded, and we need a facility like yours in New Jersey. And I said, well, all you have to do is send 10 of your employees to Oklahoma City for surgery and just make absolutely sure that the other facilities in New Jersey know about it. And poof, presto, you'll have a Surgery Center of Oklahoma sort of arrangement there very soon. But the market does work. It's much more powerful than anything that the goons and the federal government can come up with their schemes. And it is going to, and is creating a real deflationary move in healthcare here in Oklahoma City and really all over the country. And that's really the soft underbelly of the beast of the Unaffordable Care Act. If the government is attempting, I think most people agree now, to create a crisis. I call it a medical false flag. And they want to see deductibles and health spends go through the roof. So there's a crisis, and then they can ride it on their white horse and rescue us with single payer. But if the prices are falling like they are here in Oklahoma City, colonoscopy, endoscopy procedures at digestive disease specialists are a tenth of what they are at many of the local hospitals. Those local hospitals, they're going to have to respond to that, and the prices are going to fall all over the United States. And then people will be scratching their head, and they'll think, well, wait a minute, I need to think about my whole insurance thing differently. I don't know that I even need insurance, or maybe I need a catastrophic policy. What role does the government have in healthcare? And I think all these are going to be questions that are entertained that should have been. And finally, we'll begin to address the issue of cost. And people will begin to understand, as Jay and Marie and I know now, that there's actually an inverse relationship between cost and quality, which is very interesting. We are expanding at Surgery Center of Oklahoma. We have 2 operating rooms that we are making plans to add on, which will allow us to do, we think, around 1,500 surgeries a month, which would make us probably the largest surgery center in the United States. We're seeing a lot of patients from Alaska and Massachusetts and California and just all over the United States now.
Massachusetts. How can that be?
Well, the Romney Care is fully implemented.
That's right.
And some of the most expensive health care in the United States definitely coming out of Massachusetts. We're just now beginning to see more local interest, which is interesting. There's a lot of inertia with self-funded companies in Oklahoma. Jay and Maria deserve a lot of credit for stepping out of the box, because they're really the pioneers in the self-funded side to make this happen. But it's interesting in Oklahoma, there's a lot of inertia, and the companies locally that are self-funded are just now beginning to come along, much farther behind their counterparts in other states. We are excited about the addition of a full-service hospital to this, what I call brotherhood of price transparency embracers, Deaconess Hospital is definitely going through those initial pains of, okay, let's look at our costs and add a marginal profit and come up with some prices in that way. And I'm working very closely with them. And one of the most exciting things about their being involved is that this whole lie that, well, that's all well and good for Surgery Center of Oklahoma, they can do that, but the big hospitals can't do it. Well, there's one that is doing it, and so that just doesn't hold any water anymore. We're planning a symposium this spring that probably is going to happen here in Oklahoma City. All of the people that are interested in this price transparency movement, they would be coming here from all over the United States with speakers, and it's in an attempt to fan the flames and make sure that this movement continues. We are honored that you all have the trust in Surgery Center of Oklahoma and of our medical staff. They're our favorite patients, the ones who travel from far off, who have shopped and know the difference. They tend to be the most grateful patients that we take care of. And we've thoroughly enjoyed working with the Kempton Group and the Advantage Health Plan.
Thank you. Yeah, it's been a great relationship, and talk a little bit about the Texas bankers. We've had I think it's this month's IBAT magazine. There's there's an ad in there, which is actually, I don't know if you've even seen it, but it's two of your patients from Texas that came up, and IBAT featured them and their story, and they're both
good.
from Groesbeck. One of them is June, so
Yes.
June Wiskowski.
Yes.
So. But anyway, those are examples, and of course, I'm sure they wasn't high on their priority list to have to go all the way to Oklahoma, but their expectations were we're blown away as far as the quality and the relationship. And what we always like to tell people that when you start stripping out some of the layers of the healthcare transaction, and where it's between that willing seller, the facility, and the willing buyer, which is the patient or the patient's health plan, and strip out a lot of those layers, the patient experience improves dramatically. And you've talked about this, and some of the other premier providers have talked about this, is that hey, if I've got a cash paying customer that's coming in the door, I feel like we are competing for that patient, and we know that they have chosen our facility based on competitive forces and based on some research, and trying to meet that expectation. That's how you get repeat customers. I mean, that's how our community banks, that's how you all operate. It's how we operate here at the Kempton Group. And so, healthcare providers and facilities for a long, long time have felt like that wasn't really their gig, and they didn't need to do that.
That's right. We like to earn the business that we get. I don't want to have a full waiting room because we're signed up with some plan.
Right.
I want to have a full waiting room because we've earned the trust and respect of the prospective patients.
Yeah.
And it's a little different way of thinking about it.
And that's a great point. Some of the facilities and just people that are in my industry, everybody is, and you and I have talked about this quite a bit, but everybody, not everybody, but a whole lot of people are always trying to figure out, how do they own the free market? How do I turn what's happening here organically between that willing buyer, that willing seller, that free market? How do I turn that into a product that I own and I can charge admission for? And as we say, it's like they're trying to drag the free market back into a closed market. They're trying to have opaque transparency where they're selling a ticket to admission, and it's something that we have to fight all the time. That if we want to sell access to good pricing or to providers, we're going to end up right back where we're at today, because that's what has screwed up healthcare for so many years. But
And we want everybody to do this.
Yeah.
I mean, I welcome competitors, and that's why we did this, so we could introduce some competition in
Market forces,
healthcare.
you bet.
Absolutely.
Dr. Smith, I know before we let you go, I know you want to address why Consumer Reports didn't rank you.
Oh, there's a couple of reasons. One, they hit hospitals, and we're a surgery center, but the main reason is we don't take federal money, and all the data is based on Medicare cost reports. And I'd stopped taking federal money in 1992 and just decided I'd rather treat Medicare patients free than to take money from my neighbor for care I gave someone across town they didn't even know. So we've never taken a dime since we've opened in 16 years of federal money, and so Medicare, they don't even know who we are. So we've never appeared in any of those reward programs or designations. The McBride Hospital and the Oklahoma Heart Hospital, I know firsthand, are deserving of much more of an honor than Consumer Reports gave them. They really are just phenomenal facilities.
And I'm sure there's a lot of them in Texas as well, and they just need to come forward and embrace this, and eventually they will. Dr. Smith, thank you very much for your time.
Thank you, guys. Appreciate it. Thank you all.
All right.
And in
Thank
case
you.
anyone's wondering why the Texas banks weren't listed as, or why we make the Texas facilities, why no mention is made of how they ranked on the consumer reports, is the consumer reports did not include any Texas facilities at all.
Yeah.
I'm not sure why, but none of the facilities were included in their report.
Yeah. Okay, folks, I'm getting ready to, I'm kind of coming to the end of my point, and we'll turn it over to Maria. You all probably been waiting for when are you going to get something you get your meat hooks into. But I'm going to show you all just a couple of quick videos. The first video is actually is actually an Advantage Health Plans participant from Oklahoma, and she's an HR director. We thought this might be, she's been kind of living what we've been talking about here for some time as far as Healthcare Blue Book and just being more price aware, being a better shopper. She really gets it that her health plan through Advantage Health Plans is self-funded, and so the dollars, the plan's dollars and their dollars are all kind of coming out of the same pot, which is the bank. And so we just said, we need to send a camera guy out there and do an interview of her. So I'm going to click over and show you this, and this would be something that would be very suitable, I think, for there we go, thank you, would be very suitable for you all to pass around to your employees and let them see this, or definitely the HR folks that are on the call would be something good for you to hear. Now I'm going to drag myself out of the frame here real quick and start playing the video. It's not very long.
I went to the doctor, made the appointment and had the exam and got completely checked out, and then come to that point in the visit where they sit down and they go, okay, well, this is what I think. So he's talking to me about the results and what he thinks that I need to do, and he wants to send me for a test and some blood work. And I thought, well, okay, that's fine. And I started thinking, blood work, okay, I know I have a benefit for that, and I'm not sure what test he's going to send me for, but I think I need to check on that. And he started to write my chart, and he said, well, I'm going to send you here. And I had to stop him and say, wait a minute, I need to check with my insurance first. And he said, well, it shouldn't matter where you go because, it's still going to cost you the same. You'll have a copay. Of course, I knew better. So first I stopped and said, okay, our plan is self-funded. And I don't think he understood what I was trying to say. And I said, it's our money. So we're trying to be more conscious of what things cost. So I just had to say, okay, this is what I need to do. I need you to write the orders, whatever you need me to do. If you want me to go have a test done, if you want me to have lab work, and then let me go and find out a couple of places that I can go that I want to go to, and come back and you tell me which one to go to. And I really realized that, I have some control. I can help manage the cost of our premiums. The Healthcare Blue Book that's on the website, it's easy to get to, and it's easy to maneuver in. And then if you have any problems with it, it's easy to call in and get some guidance with it too. I knew that I could go and check different places and what they charge and get a fair price for that before I scheduled anything. So I didn't want him to schedule it. I wanted to check it first and then schedule it so that I knew I would be paying the least amount and still getting a good service. I would be paying the least amount and the plan would be paying the least amount.
All right, I'm just gonna pop over, we're gonna do one more little video, just wanted to share a little bit, and I know you can't see me right now, but you can hopefully hear me. We're gonna do one more video that was actually picked up here in July about what we're doing here in Oklahoma City and in Texas. It was actually picked up by our local NBC station, KFOR here in Oklahoma, and they have actually already filmed a sequel to this, and so that hopefully will be coming out here before too long. But all the pricing information that is presented in this video is actually provided by Advantage Health Plan, so this could be one of you. I'll let this rip here.
All right, Allie, thanks. Now, we contacted OU Medical Center, Mercy Hospital, and Integris Health for a comment. We received a lengthy statement from Integris, and in part, it reads like this. Instead of offering a generic price list for medical procedures, we work individually with patients to determine their financial responsibility. If you'd like to read their entire statement, we've posted it on KFOR.com.
Okay. Well, during the video, Maria and I poofed and switched places. Hopefully you didn't hear that, and hopefully the audio was not too atrocious on that. One more comment before on the two videos. The one with Lisa Gilmartin, that was not any sort of a script. I mean, we just put her in their boardroom, put a camera in front of her, and said, well, Lisa, just tell us a story, and she did. It was really interesting. And then the other comment we had on the video that you just saw with the Hospital Trade Association executive, we showed the IBAT Services Board this video, and Chris Williston was in attendance there from IBAT, and Chris looked up as soon as he said, just guys, remember, if a trade association executive ever tells you that something is complicated, watch out, because what's coming next is going to be a stretch. So I remember that every time I see that video. All right, let's pop over here and get back to it, and we're kind of on the downhill stretch here. ACA update. Maria, take us away.
A lot has changed since the transparencies here were prepared, and so I'm going to deviate a little bit from them, and bear with me if I'm not following what's written. Couple things. Number one, there are two changes that took place July 1 to the plan, and Advantage is a fiscal year trust, and therefore the changes for us take place on a July 1, not January 1. But effective July 1, prescription drugs went to, preventive part of it became a no cost to the participant. For the generics, the participant is able to obtain prescription drugs, this is birth control, if they are non-generic, only with medical necessity for a non-generic brand. And the second thing is, part of the preventive services that has come out of the PAPACA Obamacare is that women are supposed to be provided additional services with lactation and pumps. And so the plan is compliant with PAPACA. It provides a manual breast pump as part of the no cost sharing preventive services. But the trustees also voted to provide an additional benefit for a participant that doesn't want to get a single manual breast pump. They can get a different model, and the plan will pay up to $200 for that benefit, subject to deductible and co-payments, but it is outside of the normal 100% preventive. So those two things took place. The rest of PAPACA, in terms of changes for Advantage, really kick in or will kick in July 1, and there are a lot of changes coming. Everybody knows the exchanges opened up. Today's Wednesday, so they opened up on Tuesday. I've spent a little bit of time, I could say, actually, on the exchange, looking at what's out there and how you enroll. And
Did you get signed up?
No, didn't get that far. But it is pretty interesting. And I thought maybe one of the things that I would do in lieu of just going through the what we know and don't know, which is on the next transparency, is maybe I want to give you the information on the basis of what I do know today, which we didn't know 3 weeks ago. I can tell you that the exchanges are up. They are running. There are glitches, but they are expected to be worked out. The employer mandate, which is the pay or play, I think we did a webinar earlier this year on that, where the penalties, the tack hammer, sledgehammer penalties, the $2,000 or $3,000 penalties that apply to employers that have 50 or more full-time employees. Those penalties have been delayed until 2015. And so for employers, it's kind of a different game in terms of understanding what they're going to have to do, because they don't have that penalty attached to their decisions this year or for 2014, but they will come back in 2015. The individual mandate has not been delayed, and that's part of that activity going on in Washington. I was trying to think of a better word for it. Whatever they're trying to do, part of what the House is trying to put in is a delay of the individual mandate. And the administration does not want to delay the individual mandate. So whereas employers will not be penalized for not complying with the offering of health care that is affordable and of a sufficient coverage and has the minimum value, the individual is technically going to be penalized if they don't have health insurance in place for 2015. The exchanges are open. I think the plans that I looked at, I glanced briefly at the Texas plans, glanced at the Oklahoma plans. The deductibles are fairly high. The out-of-pocket exchanges are pretty high. And I think it's kind of an interesting scenario when you really start looking at it. My husband's getting ready to have surgery or have something done on his knee. And so I, consumer-driven person, said, well, when you go get your MRI, you need to ask them how much it is. And so yesterday he told me how much they told him it was, and so I went on my little phone and I was looking to see what the fair price should be. Now he's Medicare, so he keeps telling me it doesn't matter, but I go, it's out of my pocket because I'm still working and you're not. So I did this, what's the fair price? And it was really astonishing because the first thing that came up, it said, if you have health insurance, it's your copay. That's the cost. If you don't have health insurance, they gave me a range of 1,000 to 5,000. So my blood obviously rises and my temper doesn't. I don't hold my temper well, but I'll tell you that. And I thought, how ironic. What they're telling people is the cost of the procedure is your out-of-pocket copay amount, and that's what's reasonable, that's what's fair. And I thought, they missed the whole boat. But when you go on the exchanges, that's exactly what is happening. They're saying your premium cost less the subsidy is this. Your copays, your out-of-pockets, that's the cost of health care. And nothing is going beyond that to say, what does it really cost? I mean, not what are you out of pocket? What is the cost of that service? What is the cost that you're getting? And they have no means to quantify it. Why they can't quantify it, I'm not sure I can tell you just yet, but they're not. The exchanges have what is considered minimum value plans, and for those of you that have looked at them, you're going to see that there's bronze, they're called metal tiers. There's a bronze, there's a silver, there's a gold, and a platinum. The bronze is basically a 60-40 kind of copay, cost sharing. The silver is the 730, and that is the one that is used for benchmarks in terms of what people will get as subsidies. The gold and the platinum obviously get better. They're an 80-20 or a 90-10. Part of the way that the employers are going to comply with the employer mandate that was delayed until 2015 is to provide what we call a minimum value plan. And I'm going to deviate here a little bit because I think there's been a lot of confusion. The last item on there says the exchange notice will be mailed. The exchange notices were mailed. And the exchange notice, just so that you know that what you got was an exchange notice that is, quote, a model notice that the Department of Labor put out in terms of what they think employers ought to provide their employees. Now, the exchanges are designed to gather people who have no insurance. So to me, it kind of didn't make sense why employers are going to be required to provide notices to employees who already have health insurance to go figure out what they could get on the exchanges. And the only thing that is attractive is they're trying to suck employees out of employer plans on the premise that the cost to them will be lower because they will get a subsidy if they are within the subsidized levels, which basically is going to pick up individuals between 100 to 400% of poverty level, and it's based on the number of individuals in their household as to how they determine it. So when the exchange notice went out, some of the questions that came back kind of surprised me, and some of them I kind of went, okay, I need to go back to the beginning on some of these things. The exchange notice went out, and our recommendation is that you go ahead and provide it. You are not penalized if you fail to provide it. The Department of Labor did not issue their guidance on the fact that there is no penalty until I think just a few days before the October 1 deadline that had been created. The notice is what tells people where they can go get the information, what telephone number to call. Most of the exchanges are up, but they're not necessarily operational to where someone can actually enroll. Sometimes they're having to print forms and then call somebody to actually enroll. Wait times right now are kind of crazy. The enrollment period is between now and March 31, so it's a 6-month time period during which they have to actually log on and buy health care. And I think that's going to give people a little bit of chance to understand it. As you can imagine, I peruse the news quite frequently in this area just because there's so much that comes out. sometimes not in the official norms that I'm used to seeing. Sometimes you got to watch what they're tweeting out of some of these departments to figure out what regulations are coming down the pike. And I saw something yesterday that just really was kind of interesting. There was an interview that was done, I couldn't even tell you what station or who it is, because I've been flipping between CNN and Fox to see what the variations in presentations are. But there was a query that was done of people just walking on the street, and they said, would you prefer having the Patient Protection Affordable Care Act or Obamacare? And the response was almost unanimously, well, the Patient Protection Affordable Care Act. I don't want the Obamacare Act. And I sat there and I went, wow, they're one and the same. And that level of not even understanding what is out there, I think is part, for me, is frustrating, disappointing at some level, but there is a tremendous amount of misinformation and there's a tremendous amount of no information out there, so that when people are asking questions, and your employees will be asking you questions because they will go on the exchange to check out prices, it is kind of shocking sometimes that you don't realize that they really don't know much about what PPACA, Obamacare, ACA, whichever name you prefer to use is. It is one and the same. So that being said, let me just give you a couple of things to make sure that everybody understands. AHP is going to have a plan that is going to be probably a 60-40 plan, which is not as generous as any of the plans currently in place. It is going to be in place sometime during 2014. I can't quite figure out what the best timing of it is. We don't have to have one at all until July 1 of 2014, and that plan is really 2014 and with delay 2015. The plan is really intended to enable employers to provide the lowest cost option to their employees. And the purpose of that plan is to ensure that as an employer, if you're over the 50 employee, where you're subject to the pay or play penalties, that you have offered your employee a plan that is affordable, meaning it's no more than 9.5% of their taxable compensation, not their gross compensation, but the taxable compensation, box 1 on the W-2s. And as long as an employer, you are offering a plan that meets the appropriate coverage level, provides at least a minimum value of 60%, meaning that the plan overall is going to pay at least 60% of the overall cost, and it is no more than 9.5% of their taxable compensation. If that individual goes on the exchange and gets a subsidy on the exchange and gets a plan, as an employer, you're not exposed to the penalty because you have complied with your portion of it in terms of making that coverage available to the employee. You don't have to make them take your coverage, you have to offer it to them. Once you offer it to them, they can turn it down and they can go on the exchange. Technically, if you're offering a plan that is less than 9.5% or no more than 9.5% of the taxable compensation, that individual is not going to be eligible for a subsidy on the exchange. Now, that doesn't mean that the individual can't get a subsidy on the exchange, because the exchange measures eligibility for subsidy on a totally different level. They measure it on the household income level, the adjusted household income based on their tax return. So it's household income, actual household income for the calendar year in which they get the exchange-based plan. And so our goal at the AHP level is to ensure that you have a product that is going to offer the benefit that meets your obligations, so that you as an employer are not on the hook for the penalties. Whether the employee chooses to go on the exchange because their household income qualifies them and they therefore get a subsidy on their own on the exchange, that's an individual choice that each one of them is going to have to make. I'm not convinced just yet that even with the subsidies, they're necessarily going to end up in a better place, because they will have some cost and they will have some out of pocket, and what they pay is always going to be after tax, not a pre-tax contribution like most employers allow their employees to do today. One of the questions that came back on this minimum value plan for sometime in 2014 is, when are we going to have a skinny plan? And I thought, okay, I need to make sure that I clarify what a skinny plan is, and it was listed in what Megan blasted out in an email the other day on a series of just questions and answers. When you hear people talking about a skinny plan in the media, what they're talking about is a plan that is designed to provide basically preventive services only. It is a plan that has, from a scope of benefits, a reduction in benefits that is drastic in comparison to any of the plans that Advantage offers on any of the plans that are out there. It is a very, very limited scope benefit, and the IRS has said that that's sufficient to say that the employer has what they call minimum essential coverage, and therefore, as long as you offer this skinny thing, you're not subject to the high penalty, to the penalty that applies to all of your employees, but you can be subject to the penalty that applies if that individual goes on the exchange and gets coverage, because they're not getting a minimum value plan. AHP is not going to have a skinny plan. We're going to go with a minimum value plan, but not a skinny plan. And the reason for that is a skinny plan doesn't protect you as an employer from the penalties that will come into play when the employer mandate is enforced in 2015. So if you hear talk about the skinny plans, we're not doing that. We are going to do a minimum value plan. All of our plans are compliant today. And for all of the employers on AHP today, none of these penalties apply to you today. And I just want to make sure that everybody's kind of clear, because the questions, keep coming up as to whether they are or aren't.
Well, and all of the Advantage Health plans meet, they greatly exceed the minimum value requirements as far as coverage.
Yes.
And so our idea of a minimum value plan would to be able to provide a lower cost option to the banks to still fulfill the minimum value requirement.
Yes, and what it will do is it's going to shift more cost to the employee, which is what's going to make it more affordable.
Would just
Quote.
be one that the bank would just offer that, the employees wouldn't have to take it.
It's really not, it's not designed to be a win-win. It's really a lose-lose deal in my book. But we will have it for employers that need it. Would you go to
Sure.
the next one? Here's what we don't know, and I wanted to just kind of talk about a couple of these things because it's really kind of interesting to see. The contracts with the exchanges were not signed until the end of September, and some of them I think have not been 100% finalized, and that's why when you see in the media that they have some issues with the pricing, part of that is because they didn't have their contracts in place to know what the costs for the policies are until the very last minute. The exchanges are up. The large percentage, I know in Oklahoma and in Texas, of individuals who are not insured, who are intended to be pulled into the exchanges, happen to be Hispanic and Spanish-speaking individuals. The Spanish version of the exchanges will not be available until at least November 1. Not sure why they don't have them open, but the Spanish version is not available. So if people wanted to get the information in Spanish, they're going to either wait until October 1 rolls out and go on the exchange at that point on the website to get the information, or they're going to have to talk to individuals and hope they get the Spanish-speaking one to get the answers. The pricing is out there now. I think it would be interesting for you to just log on. You can log on to if you just Google Texas exchanges, it'll send you to a federal site, or you can go to the site that's on the exchange notice that you passed out to employees and look at what the pricing is. In every state, the pricing is basically based on regions. It's not one price for the state, so it's divided into states, and what happens then is that when you enter your zip code, it sends you into the pricing for the region that would apply to you. There are very few things that are asked just to get the basic pricing, namely it's your age, your sex, and whether or not you have other coverage that you're replacing or whether you're a full-time student. I mean, they're very minimal pieces of information to go in and kind of identify. If you get to the point where they're asking for household income and you put your household income, it'll tell you whether you will or won't, you might or might not qualify. And the might not qualify is because they really don't have those numbers fully integrated, and that is one of the glitches that they've got with the exchanges right now, is that when people sign up and they're getting the premium cost for the health care, the subsidies are not being calculated properly yet. I think they'll probably work that glitch out here before the end of the year, but it's a glitch. The things to watch for. So what we didn't know today, I do know some of those answers. Things to watch out for, there is a marketing blitz. I've been on the government health sites to look at some of the marketing materials, and believe it or not, they actually have canned marketing materials that are presented out there that people can just take and download. And the ones I looked at were really aimed at students. They were aimed at schools providing it to their students. There was one that was a business card with the front of it saying, something like, do you have health insurance, and the back of it giving the exchange information. And the idea is that the schools will print these things up and distribute it to their students so that the students can take them home and give it to the parents. The entities that are responsible for the navigator systems they were actually announced in mid-August. The money was granted to them for their education. There's some real concerns on the navigators because there are some things that are missing from the procedure as to who's eligible to be a navigator. There's very little that's being done to really do background checks. The information that these people have is obviously very extensive because they're going to have your name, your date of birth, your social security number, and if you want to do an identity theft, it certainly would be easy to get based on the information that they gathered just from the application. There's some pushback on people saying, no, don't do background or criminal checks on these people. You need to just let them work. The entities that I've seen that got grants to do the education for this were almost all community organizations. They were entities that were designed or worked very highly in marketplaces designed to enroll people on Medicaid. The requirements for the training were supposed to be 20 hours. The timing of when they started it and now that the exchanges are open is a very short window. There is no monitoring of the education process to make sure that people have actually got it. So there are glitches in terms of the people that are going to be doing providing the information that is going to help individuals supposedly log on and be able to enroll on the system. The other thing that is out there that we do know and is kind of still up in the air, I think for 2014 it isn't going to be in play, for 2015 it might be in play, is there is no mechanism right now to verify whether someone is or is not eligible for these subsidies. They're basically using a fair representation. If you tell them that's what your household income is, that's what they're going to work with, and that's how they're going to determine whether you get a subsidy or not. It won't be until tax returns are filed after the end of 2014, which basically means for most people that are wanting refunds, they're going to file them in the beginning of the first 2 months of January, February of 2015. It won't be until that actual number is computed that they will be able to figure out whether or not the person really was eligible to receive the subsidy. And some of the things that can happen may just be unintentionally misstated. For example, you get someone who is on a part-time job today or in January when they sign up, and they get a full-time job in March. Their household income changes significantly from where they anticipated it was going to be, because when they were asked what was your household income, they gave the income at the point in time that they were at. And now that they've got a full-time job, they got a lot more income. And I think the shocker is going to come out in 2015 when it becomes evident that there are people who got subsidies that shouldn't have gotten subsidies. And the unanswered question, and I really don't know exactly what the IRS is going to do or how they're going to do this, is whether or not they'll actually initiate a collection system to get these monies back. I guarantee you that if there are refunds due, I think they will definitely offset them. I think if it's going to be a collection mechanism, it will be a public relations disaster to suddenly start sending collection notices to people that thought that they got this health care subsidized, and now they actually have to pay some of that money back. I think that's part of a big glitch that is going to have to be worked out, and as of right now, I don't know what the answer is. On the pay or play side of it, in terms of trying to identify whether or not an individual has coverage, one of the things that is going to happen, and I've seen some of the regulations, I'm not quite ready yet to really put anything out because I think they will change significantly. One of the things that's going to happen is employers are going to be filing informational returns about every employee that they have, every dependent that is covered under their health plan, what coverage they offered them by month, and then you're going to be asked what the cost was by month so they can figure it out. Now, those forms won't be filed until calendar year 2015, for calendar year 2015, which means that information won't be filed until, won't really be available until 2016. So the idea is that between the information that the employer provides to the IRS, the information that the individual provides through their income tax return to the IRS, that somehow they're going to combine that information and coordinate it with the exchanges, which have been outsourced for the federal exchanges like Oklahoma and Texas. It is not the government that is running it, it has been outsourced. And they're going to combine all this information into the exchange database with HHS to coordinate it and figure out whether people got subsidies that weren't supposed to get subsidies or whether they got what they were supposed to get. The real concern that I think is popping up is the exchange of information is fairly significant. The systems that are in place to capture the privacy of the information and ensure that it does not get misused are not quite there. They've already had some glitches with information on some of the exchanges where people were pre-enrolling, where the data has been released without any protection. And like I said, when you sign up and you put all that information on the exchanges, there's certainly enough for any kind of identity theft if that is going to be the use for it. And they do not have those glitches worked out. So what we don't know as of today is how they're really going to resolve some of those things. The expectation for next year is that they will pick up a lot of people on the exchanges. It won't work unless they actually pick up a lot of young, healthy individuals, because those are the individuals that are intended to subsidize the cost of the older people. The people that need health care are what I would call an adverse selection. Those people will get on, and I can guarantee you that their costs will be paid either out of their pocket, or there will be agencies that will be helping to pick up the cost so that they can get the coverage for them and lower the agency's costs. And those individuals are the people that need the health care because they are sick and they are users of the system right now. So they've got to have a large portion of the healthy part of the population enroll in order to make the dollars and cents work. I don't think they have any idea just yet of what the real cost is. I don't think anybody has any idea of what the cost of the subsidies are. I don't think the insurance companies really have a sense of what the cost of actually providing the coverage is going to be. I think all of that is going to be kind of up in the air, and it's going to be sitting there until somebody can start gathering data, and I don't think it'll be done until the actual coverage begins, which won't take place until January of 2014. With that in mind, one of the things that we've talked about in the past is the PCORI fees and the reinsurance tax. The PCORI tax, of course, is the $1 a belly button, and that's in play already. For Advantage, we will pay based on our fiscal year that ended June 30, 2013. The reinsurance tax is the one that is the $5.25 a belly button for each person covered, not by employee, per belly button. And that money is going to be collected by HHS towards the end of 2014 based on belly buttons covered in the plans, regardless of what the plan year is, starting in January. That's the money that is going to be used to give back to the insurance companies to help them subsidize the adverse selection that's anticipated on the exchanges. The numbers were fixed statutorily when the laws were drafted. I think it's pretty clear that the expectations in terms of the estimates of the cost of Obamacare when it was initially priced out in 2010 is nothing like what it's getting close to in 2014. It certainly is a lot less. But the reinsurance fee is a statutorily fixed amount that is going to be used, and it is, it's up in the air as to what's going to happen when there's a shortfall that is far over and above what is expected to be collected with these reinsurance taxes, because insurance companies are going to have one of two options. Year one, they're going to have to eat the loss. Year two, the rates are going to go up. The last thing I want to say is in looking at, and you've seen the memo because I drafted a memo that went to the banks that address this. When you're looking at the success of an exchange plan, the model that we have that is historically available for us to compare is Romneycare in Massachusetts. And in Massachusetts, as the memos that the article I wrote indicated, they do have the lowest uninsured rate. They also have the highest cost for health insurance. And their biggest problem today is access. They have people that are waiting to get onto the services because there just aren't enough providers. The exchange is kicking off January 2014. If they have any level of success at gathering people to actually enroll into these exchanges, leaves the same kind of questions as Romneycare does. If you flood the market with 10 million new bodies, not the 40 million they're talking about, just 10 million new bodies, and you have a decline in the number of physicians who are treating these people, and you don't have new facilities, you don't have a massive group of new docs that are going to be providing services, to me, the picture's pretty clear. Your volume goes up, the number of providers didn't change, access is going to be slower. In some cases, I think it's gonna change. You know, my prediction is that we're gonna have a two-tiered system. And I think the two-tiered system is starting to evolve, and I think Dr. Smith clearly indicated his version of it, because I think he is on the side of that second class. And the second class is gonna be its access to individuals who are willing to pay for it, or who have plans that are willing to pay for it. And it is not gonna be the insurance companies that are providing it through the PPOs, because they're not gonna have the capacity to provide the services. So those who have to go on the exchanges to get health care will have longer waits, and probably will have a little bit of rationing, which I know is an ugly word, but I think it is going to happen, and I think you're gonna see it in 2014, and I think the mechanisms are in place to get part of that going. Those who have the self-funded plans with employers that are willing to pay for the cost of the real cost of health care, not the insurance premiums, but the cost of the health care itself, like AHP does, are going to have much better access to providers, because they're not gonna be on the same, they're gonna be on a different level. And I think that is, you know, when I look at what I don't know the answer to it. My gut tells me that we will have an access issue, and this time next year, I think we're gonna have some updates, and I'm gonna say, man, did I blow it, or boy, was I right.
Yep.
I wouldn't tell it to you unless I thought I'm right, so we'll wait to see.
Yep.
I think with that,
We have one more slide, and then we're
We
gonna
can
open it up to questions. Yeah. And just to summarize, Maria touched on a lot of things. You know, we just sent out a frequently asked questions and FAQ earlier this week. That's really something that y'all probably ought to look at. And if you didn't receive it, you can certainly send us an email or give us a call, and we'll make sure that you get that out. But, you know, this whole access, and I mean, again, you know, healthcare is kind of, there's a fork in the road, and to kind of tie back to our premier providers and the free market, those self-insured employers are definitely planning on maintaining their plans. Most of the larger employers in the country have benefit plans that are self-insured. And when we're talking to those those medical providers, those facility managers, the ones that either are physician-owned or are kind of specialists, they are the ones that are kind of coming forward, that they want to start. When you ask them, where do you want to expand your business and your practice? Do you want more exchange patients, Medicare patients, governmental type plans, exchange type plans, or do you want more free market, self-insured employer plans that are reducing a lot of the layers in the bureaucracy? As you all, as bankers, know, you all deal with the regulations. What we're seeing is that those providers are stepping forward and saying, more and more of them, if I can have more of those good patients, the ones that are paying me in 100-cent dollars, and I'm not having to deal with the bureaucracy, that's what I want more of. And really, that's what we're trying to encourage here. Again, back onto the slides. Success of our plan depends on all of us. You're an owner. You're not just a consumer of this plan. We would love to help each bank out there to create a Go for Green strategy with your employees, whether it be holding employee meetings. We've had some very creative Texas bankers that have said that they'll actually, if somebody was to use a premier provider or a more efficient provider, that they will not, if they have to be off work for a day or two, they won't count it against their sick leave. There's some pretty creative things that a bank can do to promote this concept, and it really starts at the top. If the CEO sees this as something that can help the bank and the bank's bottom line, and have a health plan that's not going to be subject to all the federal interventions, it's something that's worth hanging on to, really, with a death grip. And that's what we want to encourage you all to, and educate you all on how to do that.
And I think it's important for people to realize Advantage is a self-funded arrangement. And the beauty of it is we have a lot of smaller employers that would not be able to do that individually and on their own. In the United States, more than 65% of the employees are covered under self-funded plans, and they're usually because it's the big corporations. It's your big
or labor, big labor.
It's your big corporations, or it's the union plans. So the concept of being self-funded in the United States, that is where the majority of Americans get their health coverage. And so for AHP to be able to do that, and not have to be a Ford or
Yeah.
any of
large
the big
corporation,
companies.
right.
But to be able to get the same advantage as they get is really pretty awesome. And I think that's where you gotta own it really comes back.
Right.
Because the employees at any of these corporations are required to own it, because the employers pay attention. This is a little bit different, because we have more of you than one single employer, and it takes all of us to really kind of gather around and take that same ownership interest and promote that same
And
concept.
smaller employers have just traditionally have never looked at the health plan as something that they own. I mean,
Right.
they've always been a buyer of a product, of a widget. And if you all were in our breakout session at IBAT, you've heard me say this, that, you know, most small employers, small and medium-sized employers, you know, historically, we've always managed this line item on the expense sheet, that the health plan, we've managed that one time a year. And that is when the renewal comes and it's higher than you expected. Now we're excited, we're into management mode, and management mode means, well, you need to shop for a different health plan, or I need to raise my deductibles or my co-insurance, or I need to change the contribution level at the employee level. This is about kind of looking at this differently, and it's about creating tools and initiatives within your bank where those employees will assist in managing their health plan 365 days a year. So with that, let's open it up to questions, and I may need some technical assistance to, I think I need to open up the chat box here if I can find it. And so we can take some questions. I'm looking for the go-to meeting right there. Okay, boy, I'm gonna have to put my glasses on.
That's what I had to do.
Apologize in advance, folks. Gotta be able to see that far. All right, well, we either put everybody to sleep or we did a really good job. I'm open to either possibility.
Click,
I think that just opens and closes that, so. We'll give it a couple of more minutes, and if there's any questions, we'd be happy to answer it, and if not, we'll sign off. But I'll probably start doing the ending here, and somebody will jump in, but I want to say again, thank you all very much. I know we kept you all for quite a while. I think we had 2 hours, we're at an hour and 35, so that's a good thing. Again, if you all have any questions that you would like to speak, offline about, we're definitely available. You can go to advancedhealthplans.com and click on any of those contact numbers. Some of you all also, have your individual representatives' contact information. Any way that we can assist, please let us know. And with that, I think we'll sign off.
sounds
Thank
good.
you all again.